All right. Well, welcome to Thursday morning. And today we're going to finish up this lecture about abdomen and include a little bit at the end about radiology special procedures, but we should be able to finish that today. Again, tomorrow, because I think we're ahead of schedule and y'all have a quiz on Monday. Tomorrow, we're not going to have class tomorrow morning. But I think it would be wise for you to use that time to start studying for your quiz that's going to be on Monday. Just real quickly to address the quiz, it will be multiple choice. It will be given on ExamSoft, Moodle, Poodle, whatever it is y'all take the thing on. And Monday morning, time-wise, the exam, I don't know. I would get with Dr. Dickinson and make sure everybody's on the same page there. There will be, I think, 50 questions. Each multiple choice question will have a possibility of 4 answers. And obviously, your goal is to pick the best one of those 4 for each of the 50 questions. The questions, I think, are very reasonable. There's no intentional trick questions in there at all. I think, the best way for you to study is review the PowerPoints that you have, the recordings of the lectures. If you have really detailed questions, I would review that. If you have any questions, specific questions for me tomorrow, later today, or even over the weekend, you can email me and I will do my best to try to answer those questions. I think you will do just fine on the exam. It's not super hard, but it's very fair. If you don't study, you're not going to do well. And so I always look at this kind of situation as hopefully you would agree with me, I have done my part. I've tried to teach you as best I can I know there's a lot of material, but I've tried to teach you as best I can. Now it's your turn to do your part. Okay. And so I think, you should, if you study and you put the time into it, you should do just fine. Okay, moving on, we left off with this slide here when we're talking about abdomen radiology. The scenario that you're going to get, and you will get this all the time, it will happen to you in practice, weekly at least, is you're going to get a dog that comes in or a cat that comes in and they're vomiting. Again, the typical scenario, it's going to be 5 o'clock on a Friday and you have dinner plans with your family and you want to go get out of the clinic. It's been a long week and things like that. But suddenly this animal will show up at 5 in the afternoon or 6, o'clock in the afternoon, vomiting. The owner will say, oh yeah, well, by the way, he's been vomiting now for 3 days, but they decided to bring it in on Friday night at 5. And your basic decision is the animal obstructed or they not obstructed. And if you decide they're obstructed, that means the bottom line thing is, do I go to surgery tonight? Do I have to go to surgery tonight to save this animal? Or can he wait until the morning? Do we need to, wait on it, treat him medically, see what it looks like again tomorrow? Or do we need to go to surgery tonight and cancel my plans? That's the thing. So to cut or not to cut is the big question in those situations. So realize that you see a word here called ileus, and ileus just is a non-specific term that says the small bowel or the gastrointestinal tract is not working correctly. Okay. Usually it's not moving stuff along, and typical ileuses can be subdivided into 2 different kinds. There is either an obstructive ileus, and the other name for an obstructive ileus is a mechanical ileus, or it is a non-obstructive ileus, and the other names for that would be a functional ileus, and some people will also call it a paralytic ileus. Okay, so if you are in the camp on the left side, that is a obstructive or mechanical ileus. That's the kind that you got to go to surgery now, and it probably can't wait. Okay, if you are in the camp of a functional or paralytic ileus or non-obstructive ileus, that's the camp that you're going to treat medically with fluids and gastroprotectants and probably re-radiograph the dog the next day and see if things look better or worse, and then make a decision. That's the kind you can wait on. Okay. So what do you look for both of these? Well, with the obstructive ileus, we already described some things that you try to look for. What's the normal small bowel diameter on plain films? And remember, you should be equal to or less than the height of one of the lumbar vertebral bodies. Okay, right in the middle of vertebral bodies. And the other thing about the small bowel is the small bowel should have nice lazy loops throughout the abdomen. You don't want to see sharp hairpin turns. And all the small bowel should be about the same diameter. So we do not want to see two populations of bowel, meaning that there's some of the small bowel that looks very normal and normal in diameter, but then there's other portions of small bowel that is significantly larger in diameter, 2 or 3 times what it should be. Okay. So if you see two populations of bowel, that would make you think, uh-oh, he probably has an obstruction. If you see segmental dilatation, which means there's part of it's kind of like two populations. There's part of the small bowel that looks really big and dilated, but the rest of it looks good. That goes along with it's more leaning towards an obstructive ileus or mechanical obstruction. Okay. If you have sharp hairpin turns, or if you have stacking parallel bowel loops. Both of those would tell you there's a good chance this is a mechanical obstruction. We probably need to go to surgery. And obviously, sometimes in life you get lucky, not seems like not often, but sometimes you do, and you can actually see the foreign object. So remember that some of the objects in the abdomen that can cause an obstruction are radiopaque, meaning you can see them, like a rock or a big bone or some, any other foreign object they eat that you can, that's dense and that you can see on radiographs. Okay. But a lot of them are radiolucent, cloth-like fabric. Sometimes you get a hint that it might be there. Toys, plastic toys, parts of a tennis ball, things like that. So some of those things, a lot of times they're not radiographically visible or not obviously visible, and they don't show up. The opposite is true of a functional ileus. So the kind of animal that's going to come in when you radiograph them, if they have all the small bowels, one population, maybe it's all just a little bit big, but it's all about the same diameter. You have lazy loops throughout the abdomen. That's the kind that you're probably just going to wait on. Let's see what happens. Treat them medically and relook at it the next day. Okay, so here's an example. So this dog here's got a bunch of food in his stomach. That you can see here has got a bunch of small bowel loops. They look pretty much all the same diameter. There's some of them that are gas filled. There's some of them that are partially fluid filled. There may be a little bit of ingesta in some of them. One of the hardest things I think for people to do, and sometimes there's a couple of tricks that we have to do, is you try to decide, well, if there's food in the stomach like this, can I tell you if that's normal food, or can I assure you that it's not some type of lucent foreign debris that looks like food on radiographs? And the answer is there's no way to know. I can't tell you if that's normal food in there or a foreign object that looks like food or that could be mixing with food. Okay. So the only way to know for sure would be probably repeat the radiographs in a little bit of time and see if the stomach is empty. And during that time, you don't want to feed the animal anything. Okay. So just water, but nothing else. No food, no treats, no nothing else. Okay. And I don't know if anybody of you have kids yet, but it's the same thing with kids. Okay. So, obviously think when you were little and you came in and you're vomiting for whatever reason, one of the big things that they do is you don't feed them. You don't eat anything. Okay. So you might get some ice chips or whatever, but you're not going to eat anything. Okay. Well, you do the same thing with animals. You typically don't want to feed them anything until they start to improve. Okay. And also you don't want to feed them anything because you want to relook at that stomach and see if the stuff, whatever it is in the stomach, moves out and is gone the next time you look at them. Okay. The other hard thing I think on radiographs sometimes is you have to differentiate what is colon versus what is small bowel. Okay. The colon, we said the colon can get big, it can get little, it can be full of feces, it can be full of liquid feces, diarrhea, it can be full of gas. But as long as it's the colon, whatever is in it, really good chance it's going to pass. Okay. And so up in here, you can see on the edge of this film, this is colon, that's feces. That's probably the transverse colon right there. So this bowel loop that's coming right in here, I would bet you money that's the colon. That's part of the colon, same thing up in here. And it's definitely larger than the rest of them, but it's the colon, so it doesn't matter. Okay. All we're looking at is small bowel. The hard part sometimes on some of these animals is differentiating what is colon versus what is small bowel. Okay. So if I look over here, here's another animal here. So now the stomach is minimally distended with fluid. This is probably part of the duodenum coming out of the stomach because we said that's where it lives. But now I have this cluster of bowel loops and it looks like they're all kind of parallel. They're stacking kind of parallel to each other and they're all moderately dilated with fluid and gas. If I look at the diameter of this bowel loop that's got a bunch of gas in it, it's definitely bigger and larger in diameter than at least one of the lumbar vertebrae bodies, right? And so it may be 1.5 to 2 times the diameter, but also they're stacking upon each other. They're not lazy loops. It looks like sharp hairpin turns that's coming in this way. So this would be an example of something that is really suspicious for an obstruction. Okay, we can see the colon here. It's got feces in it. It's got gas. It may have a little bit of mineralized debris in it right in here. So we know for sure that's not colon. All these things are not colon because I can see the colon here. Okay, so I know number one, they're small bowel. Number two, they're moderately dilated. Some of them look very minimally distended, like this section of duodenum. Some of them are moderately dilated. So I have two populations of bowel. They're stacking upon each other. So I think there's a really strong possibility this animal, this cat, needs to go to surgery. Okay, here's another dog here. So this dog comes in, it's 5:30, comes in, he's vomiting, you take x-rays, and that reminds me of another thing that you should keep in mind too. In these scenarios, when the dogs come and cats come in at 5:30 in the afternoon and they're vomiting, what's the first thing that you should do? Should you ultrasound them first, CT them first, MRI them first, or radiograph them first, assuming all of them are available to you and they all cost the same amount of money? Okay. And the answer is you should radiograph them. Radiographs are the bread and butter. Okay. So all of these dogs, and you will have other people, internists and maybe emergency clinicians that disagree with that. But the correct answer is you always want to shoot plain films first. And part of the reason being is that not everybody is skilled at ultrasound. Okay. And so that's a thing. And the other reason is because radiographs are cheap and dirty and really quick. Okay, you can get 2 views or 3 views of the abdomen, and it's really quick. And so that's that's probably the first modality to go to. If you can't make a decision based on the ultrasound, based on the radiographs, do we need to go to surgery or not? Then that's when you typically will go to ultrasound next. Okay, so if someone was to ask you on a quiz, you have the dog that comes in emergencies vomiting, what should you do first, rads or ultrasound? You should probably select rads. Okay. Okay, back to this dog here. Here's the stomach. Okay, there's the pyloric region of the stomach down in here. He's probably got, that's probably a right lateral view. So he's got a rounded fluid filled opacity in the stomach. This is gas up here in the fundus. I got some small bowel loops through here. Got a really big dilated bowel loop right in here, and this thing here right in the middle. So that, if I'm reading this, I think that's probably feces in the colon or the cecum because it lives right there. This great big old dilated bowel loop here is probably the colon. It kind of got some, it has some fluid in it here, so a little bit of impending diarrhea. This is the rectal area caudal to the pelvis, so it's got gas in it too. So that is most likely colon in here because that's where it lives. That's the cecum. But if that's colon, what are these? Okay, so you have to convince yourself, if these are small bowel loops right in here, even this one right in here, they're really big. Okay, so this diameter of this bowel loop is really big. The diameter of that bowel loop here is really big. That one's really, really big too. On the other hand, over here, I got small bowel loops that have fluid and gas in them. They look pretty normal. Okay, so now I have the two populations of bowel, right? Really big dilated sections of small bowel, normal dilated sections of small bowel down in here. And they're not colon because now I can see the colon. Okay, so again, most likely this is a mechanical obstruction and probably needs to go to surgery. And of course, you always correlate whatever you see radiographically with the clinical signs and history of the dog. Okay, another good rule I think to keep in mind with radiographs is you treat the animal, you don't treat the radiographs. Okay, and so you always correlate with any imaging modality and any blood work and anything else that you get. You correlate that with common sense and what is the dog doing clinically to help make your decision. Okay. Obviously, this dog here, you can see too, down in this part of the pylorus, it's got some fluid in it. There's a little bit of amorphous, like mineralized debris. It looks like it's probably stuck or lining the wall of the pylorus down in here. And that could be some sand-like radiopaque stuff that the dog ate. But the other thing that I will caution you about is you always wanted to ask the owner, did you give him any medication recently, like in the last couple hours? Okay, because some of the medication over the counter stuff that owners tend to give, like Pepto-Bismol or an Amphigel tablet or a Pepto-Bismol tablet, some of that stuff is radiopaque. And so this could be just a little bit of dissolving medication. that the owner may have given in the past. So you want to ask them that before you decide, could that be foreign debris or not? Okay. So this animal here, probably you want to cut. What about this animal here? So this is another animal here that comes in, he's vomiting. Okay. This one here, it's a little harder to tell what's colon, because you know it's up here somewhere, and what's small bowel. Okay. So it's a little harder to tell. This area in here looks kind of funky, and that would be a weird place for colon, but I can't tell you that 100% for sure. Stomach looks minimally distended. Portions of the small bowel back here look very minimally distended. So the question is, what is going on right here? Okay. And again, you would want to palpate the animal, look at the clinical signs. If I had to bet, I would bet this is a section of dilated small bowel that's kind of bunched in appearance to almost plicated in appearance right up in here. So if this animal is actively vomiting, can't keep anything down, been vomiting for 12 hours, 24 hours, maybe 3 days or whatever it is, really good chance this animal probably also has a mechanical obstruction, maybe a linear foreign body due to lucent debris in there or something, and probably needs to go to surgery. But I can't definitively tell where the colon is. So what's some things that you could do before you go to surgery and spend, a fair amount of the owner's money to convince yourself a little bit more strongly that, yeah, this is a surgical candidate? Okay. So one thing that you can do is try to define where the colon is. And so one option there is you can get a catheter, like a red rubber catheter or something, and you can put up the rectal area and feed it up into the colon and then reshoot the film and see if you see the catheter in that area. And that will define where the colon is versus this stuff down in here. Okay. The other thing you can do is you can get the same catheter and put it only partially into the colon. So maybe you stick the colon in up through the rectal area, you stick it up to about right here, and then you put air in the colon. So I would highly advise that when you do this, you use a syringe connected to the catheter and don't blow in it. But people have, and I wouldn't recommend that though. But so you fill the colon up with gas and then you repeat the films. Okay. So once you fill the colon up with gas, it should be a nice, well-defined radiopaque gas-filled tubular structure that's sitting up in here. And again, that procedure is called a pneumocolonogram. And it's easy to do. It's cheap, doesn't cost any really any money to do. And it's real easy. So stick a catheter in there, fill the colon up with gas, and reshoot the film. And that will help you define what's colon or what's small bowel. And the other way is if you are fluent in ultrasound, stick an ultrasound probe on the belly. And that's a really easy, quick, and dirty way also to tell, yeah, the 100% I know this animal's obstructed and needs to go to surgery. Okay, what about this dog here? And again, look here, there's a catheter in here. There's a catheter that somebody stuck up the colon and probably put a little bit of gas in the colon. It needs a bunch more to help differentiate it for sure. Okay, so we know there's the colon. It's got some impending diarrhea in it right in here. So colon's living up in here. But then I got these areas of small bowel down in here. This is pretty dilated small bowel. It looks like it's got some weird gas opacities, and it looks like there's something probably stuck in the small bowel right in here. It's definitely big. On the other hand, I've got other portions of small bowel, like right in here and up here, that look very normal in diameter. Okay. So again, two populations of small bowel. Some of the small bowel is significantly more dilated than others. And here I can actually see radiopaque debris in that area of dilated small bowel. So really good chance that this dog's obstructed. So things that can cause a mechanical obstruction: the dog ate some type of lucent foreign body, a radiopaque foreign object. It can have disease of the bowel wall itself. So lymphoma or adenocarcinoma that happens in the bowel wall itself can get so big that it will cause an obstruction and nothing can get through the bowel. Okay. An intussusception, we'll talk more about intussusceptions in ultrasound, but does everybody know what an intussusception is? It's where one part of the bowel telescopes up inside another section of bowel. Ultrasound wise, it's super easy to find. There's nothing else that looks like those with ultrasound, and we'll talk about that. The hardest part about intussusception is learning how to spell it. Okay. And then linear foreign body. So linear foreign body is the cat that eats dental floss, the cat that is playing with yarn and eats it, and it causes an obstruction, plication, and can actually saw through the linear foreign object through the small bowel, leading to a ruptured bowel segment and gas in the abdomen. Okay. Other things that can cause a linear foreign body in dogs, especially, they get into some food and they eat plastic wrap, like saran wrap. I've seen aluminum foil do it, but aluminum foil a lot of times will break into smaller bits and not cause a complete obstruction. Undergarments, women's panties, bras, things like that, any, rope, anything that these dogs can eat that's linear and rope like, once it gets in there, can cause an obstruction. And a lot of those things are not radiopaque. And so you have to look for other things other than the object itself that would suggest the dog is obstructed. Okay, so things that typically are lucent that you're not going to see if the dog ate, a plastic toy, okay, a greenie, one of those nylabone kind of things. None of those are going to be radiopaque, but they can still cause obstructions. Okay, most ingested wood, dogs that eat bark chips, mulch, things like that, usually are not radiopaque. They can cause an obstruction, but you won't actually see the foreign object itself. Glass is kind of plus or minus. Some glass is radiopaque if they eat glass, and some of them is not. So that's kind of plus or minus. Now you ask yourself, why would a dog eat glass? I have no idea. But a dog is a dog. Why would a dog eat cat poop? I have no idea. But a dog is a dog. They eat the most odd, bizarre things that you can imagine. Cloth or fabric. Again, the dog that eats panties or bra or whatever it is, typically is not radiopaque. Other things, seeds, peach pits, avocado pits, things like that. You're typically not going to see, but they can still cause an obstruction. This is that same radiograph. This is a cat. And again, just a reminder of these, quote, high obstructions. So if you see a super dilated stomach, but the small bowel all looks fine, here's the colon. Okay, small bowel looks fine. But in a cat, especially, you'll see these, quote, high obstructions. And again, anything that can get through the esophagus, in the stomach, and then it gets stuck in the duodenum. And the big one I see nowadays all the time is Nerf bullet heads. So the head of a Nerf bullet. Okay, another weird one, this you will probably maybe see in your career, but this is a condition called feline dysautonomia. It's a neurologic condition where the bowel basically loses its ability to contract, and the entire bowel, whether it is the part of the entire gastrointestinal tract, the esophagus here is super dilated, the stomach's dilated, the small bowel's dilated, the colon's dilated. This is just a weird condition that cats can get every now and then. Just keep it in the back of your mind. If everything in the entire cat is dilated, organophosphate toxin can do the same thing. Okay, this is another one here. And at first you're going to think, well, here's the stomach. There's, nothing else in the bowel segment in the abdomen can be that big. So it's got to be the stomach. The cecum's not going to do that. Small bowel's not going to be big and rounded and oval shaped like that. So that has to be the stomach. Okay. And then you're thinking, well, I don't think the stomach's malrotated because here's probably the pylorus and the fundic regions up in here. But the weird thing when you're looking at this is, where's the small bowel in relation to the stomach? Okay. And if I look, all of this stuff up in here is small bowel. Is it normal to have all of your small bowel cranial to your stomach? And the answer obviously is no. And so this is not a gastric dilatation and volvulus. This is a mesenteric volvulus or mesenteric torsion. So in this case, the stomach hasn't flipped dorsal to ventral, but the stomach and small bowel have flipped. So all of the small bowel has not now gone cranial and the stomach is caudal. And again, that's usually we need to go to surgery right away. If you don't, this dog's going to die pretty soon. So that's called a mesenteric torsion. You won't see them often, but every now and then you will. And again, great big stomach, big dilated stomach, and the small bowel should be down here, but nope, in this case, it's all up here. Okay, radiopaque foreign objects, we talked about that. Bones, rocks, some glass, metallic objects. So what's some diseases of the small bowel itself that can cause a mechanical obstruction? Again, if it's a cat, you're going to bet lymphoma. Cats get lymphoma in their bowel loops all the time. It can be in the stomach, small bowel, or in the colon. If it's a dog, adenocarcinomas kind of rank up there with lymphoma that they can get. And again, these are going to be much more common in middle-aged to older animals because it's some type of neoplasia. And then the other types of neoplasia every now and then you'll see are smooth muscle related tumors. Remember, your stomach, your small bowel, and your colon are all made out of smooth muscle. And so any smooth muscle tumor like a leiomyosarcoma or a leiomyoma, the benign version, can cause, if it gets big, it can cause an obstruction of the bowel itself where that tumor is located. Again, intussusceptions, where telescoping of one section of bowel up inside another, The whole process, the whole thing together is called an intussusception. The inner portion of an intussusception is called the intussusceptum. The outer portion of an intussusception is the intussuscipiens. Okay, it's the receiver of the intussusceptum. Okay, and again, most of the dogs that get intussusceptions are going to be large breed dogs. In my experience, large breed dogs, usually about a year of age. And the most common spot in dogs to get one of these intussusceptions is going to be in the ileocecal region. And a lot of times these dogs won't come in vomiting. They come in with intractable chronic diarrhea. They've been treated for parasites. So you're looking for parasites, and lo and behold, their diarrhea is caused by some type of an intussusception in the ileocecal region in a lot of these dogs. It can happen anywhere in the small bowel. It can even happen in the stomach, an intussusception, but most commonly in the ileocecal region. Okay, linear foreign bodies, we've kind of mentioned that, the string, dental floss, plastic wrap, undergarments, blah, blah, blah. Sometimes, here's the stomach, a dog's got a bunch of dog food in it, but now it looks like all of the small bowels kind of up in here in the right cranial portion of the abdomen. And these are all small bowel loops up in here. I see no small bowel loops over here. That's the spleen, okay? And so that's a little bit worrisome. And he's got this little metallic foreign object in here. So that may be some type of and it could be a needle, it could be a wire or something like that, and it may have a string attached to it. A lot of times if you do see sewing needles in the gastrointestinal tract, for the most part, especially if it's a cat, dogs and cats don't eat needles, but they do eat string they play with, and most all needles like that you're going to see are going to have a string on them. They're going to have a thread on them. Okay. And so sometimes all of the small bowel loop will kind of gather up in this area. And that's because it's drawn up as it does peristalsis and tries to move this string along that's in the lumen of the bowel. It tends to climb the linear foreign object, literally. And the only part of the small bowel, if you remember, that is fixed in its location and not randomly distributed around is the duodenum. And so it tends to, and the duodenum is located right here. And so it tends to climb up, and a lot of the small bowel tends to bunch up in the right cranial abdomen where the duodenum is located. Okay. So that's one thing you can look for a linear foreign body. A lot of the linear foreign bodies are a little bit iffy sometimes on radiographs, and you have to ultrasound the animal to know for sure. Okay. Extraluminal, what's something that a big mass outside of the bowel that can push on the bowel? Well, that's pretty rare, but if you can get a huge splenic mass that comes in and it pushes on the small bowel or the stomach, then sometimes it can cause vomiting because it's actually squishing the small bowel and compressing it so much that the dog vomits. But that's not real common. Okay, colon and cecum. A couple of things. Remember, the colon and cecum, it's kind of its own thing. It's got its own mind. It gets big, it gets little. It can move around the abdomen. It kind of does what it wants to do in general. Okay, this is a condition in cats called megacolon, which is self-explanatory, the name. And most of these cats that get this are middle-aged to older cats, and for whatever reason, the colon has lost its ability to push out feces. Okay. Usually this is idiopathic, which means we don't know what really causes it. A lot of times it will also be associated with chronic renal disease and chronic dehydration from chronic renal disease in cats. But if you look, poor kitty here has got tremendously dilated, very large diameter feces in the colon and a little bit of gas. This is all feces in the colon. Stomach looks great, little fluid and gas, small bowel that we can see, and a lot of it is in place of this. The small bowel looks like it's probably okay. So just tremendously dilated colon. And these kitties will go in, they stop eating because they're so obstipated by this feces. They quit eating, they start to go downhill, they start to lose weight, and you radiograph them, they got these huge colons. Okay. They can't go, they go in the litter box, they try to go, but nothing comes out. They push and push and push and nothing comes out. Okay. You can give these kitties an enema. But typically these will just recur. A lot of people will put them on, dietary supplements, stool softeners, things like that, fiber diets and stuff like that. But unfortunately, a lot of these cats, it just keeps recurring. It keeps recurring. Ultimately, some surgeons will go in, a soft tissue surgeon, and you can take out the majority of the colon to relieve these cats. But now you've created, instead of a cat that's constipated, now you've created a cat that's got constant diarrhea. So kind of a trade-off. Which one would you want? And so megacolon in a cat. Here's another kitty that's got megacolon. So this kitty could use an enema. Okay. Then again, who couldn't, right? So this kitty needs a big enema. Okay. So what about this one here? This dog, if I was a dog, this could be me because this would be my luck. Okay. So do you take this dog to surgery? And the history with this dog is he's really painful when he's defecating, to the point that when he's trying to defecate, he screams out loud when he's trying to poop. Okay. And so you're looking at him and you think, well, crap, why is he doing that? Well, there's a couple of reasons why. So let's look at that. So here's his liver. Liver looks all right. That's probably maybe spleen. I don't know. Maybe that's the spleen. I don't know. So here's the stomach. Stomach's minimally distended. Okay. Here's a small bowel. Small bowel loops great. Minimally distended, fluid and gas. Here's the colon. So definitely colon coming out here. Colon, transverse colon. Cecum's probably sitting up here somewhere. The kidneys are up there. Here's the urinary bladder. Colon's only minimally distended. So I don't see peritoneal fluid. His detail looks pretty good. So why is he screaming? Anybody got an idea? Why is this dog screaming when he defecates? There's two reasons on this radiograph that will cause that.
Two foreign bodies.
Where?
Near the rectum.
Near the rectum, yeah. So that's why this would be me. If this would be my luck. This dog ate a needle or a wire or whatever it was. It went all the way through the oral cavity, through the esophagus, through the stomach, through the small bowel, through the colon, and got stuck in my rectum. Okay, it came so close to passing. Okay, but then it broke off and got stuck in your rectal area. If you had a needle in your rectum sticking through your rectum, you would probably scream when you defecated too. Okay, and so that's an issue. And so, yeah, we got to go take that thing out, and probably the dog will be a lot better. There's another reason on this film that this dog could be screaming when he defecated. Okay, we have to remember that even though we teach radiology in parts, thorax, neuro, abdomen, we have to always look at the whole film. Okay, we can't just look at the abdomen, even though we're doing an abdominal section. And if you look at the spine up in here, he's got these lytic lesions on adjacent end plates here and probably right here too. Okay, so what would that be called? Very good. That's called discospondylitis. But that's awesome. So he's got discospondylitis, adjacent lytic lesions of vertebral end plates right here and here. And we said that's usually caused by staph or strep. It can cause extreme pain. So dogs, when they're trying to position themselves to defecate, if they have back issues, intervertebral disc disease or discospondylitis, they don't like to position to get in the posture to defecate. And when they start pushing to defecate, the Valsalva maneuver to push to defecate, then it's painful. Okay, so that could also explain maybe some pain while this dog is trying to defecate. Okay, this is another one here. This is an ooh-ah kind of thing. I've had several times veterinarians that, the dog is painful or whatever, and they shoot a VD view of the pelvis and they see this lucency right here, and it's in the region of the ischium. Okay, here's the ischium, here's the ischium. So is that a real lytic lesion? Does he have a tumor in the ischium, or is it artifact? And don't be surprised that if you look at this dog here, here's where we're looking. There's a gas opacity right in here. That is gas in his anal sac. Okay. And I don't know if you have ever worked in a private practice, in a veterinary practice, and you're struggling with the dog and you're trying to hold him and restrain him and get radiographs or ultrasound him or whatever you're getting blood from, whatever you're trying to do. Some of these dogs get all nervous and they express their anal sacs. Okay, usually right in your face. Okay, and that's always a nasty bad thing, but that's part of veterinary medicine. Okay, some of the dogs, once they express their anal sac, they actually suck up air into their anal sac. So that's what that is. That's air or gas in his anal sac that now superimposes over the pelvis. So it's not a real lytic lesion. It's just an ooh-ah, iffy kind of who cares kind of thing. Okay. It's really, really good. I always thought that I'm really happy that people don't have anal sacs because if you got really nervous in the middle of an exam or nervous on a date or whatever, and then all of a sudden that would kind of ruin things. So anyway, it's a good thing that people don't have anal sacs. Okay, then we're going to talk real quickly about some special procedures. So, special procedures are procedures that we do radiographically to help us make a more definitive diagnosis. So, special procedures used to be done all the time, especially before ultrasound was around. And there are still some times where you will do some special procedures. And we're going to run through these really quickly because number one, a lot of them aren't done anymore. But I'm just going to tell you just basically a little bit about why you would do one and what it can do for you to help you make a more definitive diagnosis. Okay, so here's just a list of a couple of things. We already talked about the pneumocolon study. Okay, so an upper GI study is we used to do these if you had plain films and you thought the dog might be obstructed, but you can't tell for sure. So you take the plain films and you're just kind of on the fence. You can't tell if he's obstructed. Do I need to go to surgery or do I need to wait? I can't really tell. Nowadays, you take the plain films, and if you end up with one of those that you're not really sure, you go straight to ultrasound. Ultrasound is going to help you out in almost all those cases, okay, to make it you lean one way or the other. Before ultrasound, we would do an upper GI series, which is otherwise called a barium series. So you would give the dog a bunch of barium liquid and then take serial radiographs over time and watch it go through the intestinal tract. Okay. Hardly anybody does upper GI series anymore. The only people that do these is if they don't have availability to ultrasound, and they will still do some of these. So you use barium. It comes in a jug. I'm not going to spend much time. It looks like this. It's white liquid. It's kind of thick, kind of like a pancake batter, maybe a little thinner than that. And then you would dilute it half and half with water, and you'd give a bunch of it. You typically give it via stomach tube into the dog's stomach directly. You don't let them eat it with food. You don't want to give it by mouth because they tend to aspirate it if they struggle and stuff like that. And you don't want them to aspirate barium into their lungs. That's a really bad thing. Okay, so typically you will give it via stomach tube, and you fill up the stomach with barium. When you again, you don't want to give it by mouth. You don't want to give it to where they could aspirate it. Barium in the lung like this. This is a cat, and we filled this cat's or the vet filled this cat's lung up with barium solution. There's no way to get the barium out of there, and then you can't exchange oxygen, and that's usually a dead cat. Okay, and then it usually is a lawsuit after that. Okay, if they aspirate just a little bit of barium, that's not a big deal. But if they fill up an entire lung with barium, that's not a good thing, and you don't want to be in that position. Okay, some veterinarians will use not barium but iodinated contrast material. That's not recommended for routine upper GI studies. You don't want to use that. This stuff tastes really bitter. It's kind of oily, and it moves. It doesn't. It's not really it's radiopaque, but not as obvious as barium, and it moves through the gastrointestinal tract super fast. And so a lot of times and they don't realize that, so they'll give some of this stuff by mouth. They'll wait 15 minutes, and by then it's already all in the colon. Okay, so no one recommends using iodinated contrast material to do upper GI studies. How do you do one of these? And this is the only thing right here that you need to know, which sounds stupid, but I want you to know the dose if you had to do an upper GI study using barium solution in a dog. The dose is 6 to 10 mils per pound of body weight. And the bottom line that you need to know, that's a lot of barium. That's a whole bunch. And so if you have a 60-pound dog, you may be giving them almost a liter of barium. And the whole key is you have to give enough barium to fully distend the stomach. Okay. If you have a Labrador and you give them 10 cc's of barium, it's just going to pool in the stomach and just sit there. Okay. And that does you no good at all for anybody. Okay. So you have to give enough barium to properly distend the stomach and make it nice and big, and then you watch it go through. Okay. So 6 to 10 mils per pound of barium solution, not mixed with food. And they also you want to make sure that the stomach is empty before you do it. So you take plain films of the abdomen. If there's food in the stomach, then this is a waste of time, because once I give the barium, it's going to mix with all the food in the stomach, and I can't tell you if that's a foreign object or that's just normal food. So you want to make sure the stomach is empty before you even start one of these things. So you give the barium 6 to 10 mils per pound via stomach tube, and then you start taking films. Okay, so you take films basically for every 5 minutes for the first 15 minutes, and most people will take both laterals and a BD view. And then for the first hour, you take another film every 15 minutes. And then for the next 4 hours, you take another film about every 30 minutes. And you keep doing that throughout the day until the great majority of the barium is in the colon. Okay. A proper upper GI study in a dog may take 8 to 10 hours to do. So you don't want to start one of these at 3 o'clock in the afternoon. You always want to start them pretty early in the morning, and you try to remember to stick to this timetable. Okay, upper GI mistakes that a lot of people do. They don't administer enough contrast to distend the stomach. This is we give a Labrador 10 cc's of barium will do nothing for anybody. Okay. They don't administer it via stomach tube, but rather they give the dog by the dog's mouth. It can lead to ingestion of a lot more air and also lead to more aspiration of barium, which is not good. And also, again, this is probably the biggest one. Veterinarians get lazy and they say, I don't want to pass the stomach tube and give the barium. And so they just put it in a bowl and mix it with dog food and let the dog eat it. Okay. But the problem with that, again, is now I can't tell what's foreign object and what's food. Okay. So again, that's usually a waste of time. Okay. Here's our barium solution. That's what you want to use for one of those studies. This is our passing of the tube. So here's our dog. We have this guy. Usually I give him just a little bit of sedation ahead of time. And then you pass the stomach tube into the stomach. And then once it's in the stomach, then you give the barium pretty much as fast as you can. I'm always paranoid here when I pass the tube. I want to make damn sure the tube goes through the esophagus and ends up in the stomach and not in the trachea. And so what I typically do once we pass the tube is I flip the dog over real quickly in lateral view and just shoot a real quick x-ray because I want to see the tube in the stomach before I give the barium. Once you verify that tube is in the stomach, you start loading the dog up real quickly with barium, and then you start shooting your films. Okay. How long does it take contrast materials barium solution to get through the dog? From the stomach through the colon, it's extremely variable. Okay. Typically, the stomach should be empty of barium, maybe in 30 minutes to 2 hours. It passes through the small bowel in up to 6 hours, and most of it's in the colon up to 8 hours later, but it's extremely variable. Okay. Cats is a little bit different. Cat's GI system works really quick. So once you give barium to a solution to a cat, once it's in the stomach, pretty much every time it's going to be in the colon within 30 minutes to an hour. It goes through really quick. Okay, so here's just some examples. There's nothing to look at here except notice how big the stomach is. The stomach is fully distended with barium solution. It doesn't just have a little pool sitting somewhere in it. And then you would watch it go through the duodenum and through the small bowel. And again, nobody's going to do these. They're a pain in the ass to do. They take forever. And nobody's going to do these if you have ultrasound anymore. Okay. The other one thing that barium will do for you is it's kind of like Pepto-Bismol in that it gives that coating, soothing effect. And so dogs that do have like enteritis or parvoenteritis and things like that, barium does have a therapeutic effect. So it does, if they have enteritis, it will help that. It'll actually have a therapeutic effect on it, not just being diagnostic. Okay, so here's a upper GI study. He's got a foreign object. There looks like some kind of peach pit or something that you can see here in the small bowel. So we're not going to spend any time really on that. This dog had his stomach. He had a linear foreign body intussusception kind of thing in his ileocecal region. This is a dog that ate panties. This is where the duodenum normally is. Now the duodenum's all plicated and bunched and contrast enhanced with barium. And again, nobody would do that at this point. You're going to ultrasound the dog for those. Okay, one thing I will caution you about, if you do one of these studies in a cat, dogs don't get this. It's a cat thing. They get this, what's called the string of pearl sign in the duodenum. This is stomach. This is cranial duodenal flexure. That's the descending duodenum. And it looks like there's these string of pearls, these little radiopaque bubbles that form only in the duodenum and only in a cat. And this is incidental and temporary. If you would re-radiograph this cat probably 2 minutes later, the duodenum will look perfectly normal. Okay. I don't know why it happens in cats, but it does. And so just realize that cats can get in only in the duodenum, this string of pearl sign, and in a cat, it's incidental. Okay, gastrogram is like a miniature upper GI study where you're only concentrated looking for the stomach. So here's a part of a gastrogram. No one does them, so we're not going to worry about it. The only thing that you can do, sometimes you can do what's called a negative gastrogram, and I term this a cocogram. Okay. And this is basically playing with the stomach bubble, which remember we reviewed the stomach bubble. And if you do it left lateral versus right lateral, the stomach bubble is going to go in different places. Well, if we actually introduce air into the stomach via you pass a stomach tube and blow in it, or you use a catheter to fill the stomach up with air, you can put negative contrast, i.e., air that shows up more black into the stomach. And if you have a foreign object in the stomach, like a ball or panties or whatever that could be inside the stomach, you can put gas around it, and now you will be able to see it on radiographs. Okay. And so a cocogram is where the dose for this is 1/2 of a Coke. So your any Sprite, Coke, Dr. Pepper, probably a beer would work. I don't know, but you put you half a can, and you this time you want the dog to swallow as much air as possible. So you give it by mouth, and the dogs don't like that carbonation, and so then they swallow more air, which for this effect it's your advantage. Okay, and so and then as soon as you give them half the Coke, then you shoot films, and that carbonated beverage will go in the stomach and kind of blow the stomach up with air. And you take both lateral views, playing with your stomach bubble, and see if you can see that air outline a foreign object that could be in the stomach. It doesn't work for anything in the small bowel, only if you suspect a gastric foreign object. Okay. Why is the dose a half a can? That's because that leaves you the other half a can that you can drink. Okay. That's the only reason. Okay, so here's our stomach. We gave the dog a Coke or half a Coke, and now you can see there's some type of foreign object that's stuck in his pylorus, and without putting gas around it, we would have never seen it. Okay, esophagograms are used with barium solution to evaluate the motility of the esophagus. You'll probably never do one, but the esophagus, you can, when we do these, we typically do them under fluoroscopy. So it's a video, and you can actually watch this stuff go down in real time on a computer monitor. Okay. So it evaluates the motility of the esophagus, make sure it has normal motility and can cause aboral movement away from the mouth into the stomach through the esophagus. Sometimes people will do these for a condition called megaesophagus, looking for esophageal distension or a foreign object in the esophagus. Typically, if you want to do one in practice, you're not going to have fluoro, and you're probably going to turf these to a specialty center. Okay. Megaesophagus is kind of like megacolon. Megaesophagus in an animal is the esophagus loses its function to move food along. You probably talked about this when you talked about thorax. This dog here has a hugely dilated esophagus with gas in it and a little bit of fluid. That's all esophagus. On plain films, as you already learned, you normally don't see the esophagus. So this dog has severe megaesophagus, a great big dilated fluid-filled esophagus. Okay. Usually you don't need contrast. You can, here, this one we did give contrast, but most of the time you can diagnose it on plain films because the esophagus is so big and dilated. Urethograms and cystograms. I'm going to power through this because we only have like 5 more minutes. So urethograms and cystograms is we're looking for a tear in the urethra, a stricture, a stone in the urethra. And the cystogram part of it is where we're looking at the urinary bladder for a bladder tear. So a tear in the bladder, and we can see leakage of contrast that we give into the peritoneal space. So how would you do one of these? You would pass a catheter into the urethra, and then you use this iodinated. You want to use barium solution. You only use barium in the gastrointestinal tract. Anywhere else, you don't want to put barium. Okay. So in case of this, we're using it to study the urinary bladder and the urethra. That's not part of the gastrointestinal tract, so we don't use barium. We will use iodinated contrast material, and we end up injecting through a catheter contrast material into the urethra and the urinary bladder. This thing with the cystogram is if we want to blow the bladder up, we take a radiograph, we can see the bladder now. It looks like a big lemon, big distended lemon. It's white, it's radiopaque because we gave contrast. And if you're looking for a ruptured urinary bladder, that contrast, then sometimes you'll see leaking into the peritoneal space around the bladder. Again, why doesn't anybody do these for the most part anymore? Because you can ultrasound the cat and get the same information. Okay. So we're not going to talk about that much. An IVP is another study where you would give contrast, iodinated contrast material. This time you give it through a catheter IV, so intravenously, and iodinated contrast material is actually excreted by the kidneys into the urinary tract. So an IVP allows you to look at the kidneys better and then it will also opacify and you can see the ureters. So if I'm looking for an IVP, now we just gave the contrast, the kidneys are a little brighter than they should be. That's because the kidneys have iodinated contrast material in them. And if we wait just a little while longer, we can see here's the pelvic region of the kidneys where the contrast is now filling it. Here it is in the other kidney. And these white tubes right in here are the ureters. Okay, so it opacifies the ureters. And so if we have a little stone in the ureter, typically you'll see a little filling defect, and the ureter proximal, that would be big and dilated. Okay, sometimes we will do these also to look for what's called ectopic ureters, where the ureters don't enter into the normal trigonal region of the bladder, but they will continue along here. It's a congenital defect. So they're born with it. And typically that instead of entering into the bladder, it empties into the vagina, into the prostate or the urethra, and those dogs constantly dribble urine. So people nowadays, if you're looking for ectopic ureters, the best way to do it is with an IVP. So you give this contrast stuff, but people won't even do radiographs anymore. You just do a CT of the animal to see these. And again, if you suspect an ectopic ureter in an animal, probably the best thing to do is turf it to a specialty center or a radiologist. Okay, pneumocolon, we talked about that. Why would you do a pneumocolon? This is where you're going to pass a catheter, you're going to fill the colon up with gas. And the people, the only real reason to do pneumocolon studies is you're trying to differentiate what is colon versus what is small bowel on a plain film. Okay, so here we have this animal actually had an intussusception, a colocolic intussusception. So part of the colon intussuscepted inside the colon itself. Okay, so he's got an intussusception, but most of the time you're going to do this to differentiate on plain films what is colon versus small bowel to try to help you decide, does he have a mechanical obstruction or not? Okay, that's the end of abdomen special procedures. And that's the end of what you're going to have on your on the exam on Monday. Okay, and it's also the end of today's lecture. So I'm giving you the last hour back to yourself also. Okay, I'm such a nice guy. Any questions so far? I know it's a whole bunch of information that we've gone through, but you know, hopefully you got something out of it. Now it's your turn. Please study. I want everybody to do really well. If everybody makes an A on this test, that's ideal. That means I did my job and you did your job. Let's try to make that happen. Okay.
I
So,
have a question.
pardon, yep, go for it.
There were a couple extra slides on our slide set that Robert